Welcome to Medical Student. Today we're going to talk about the insulinoma, like what is insulinoma, how to diagnose insulinoma, and how to differentiate the insulinoma from other related condition. So let's see in the description. So guys, insulinoma are predominantly benign beta cell tumor that is associated with increased insulin production. Okay, so it is a tumor which will increase the insulin production, while most insulin are sporadic. So what does it mean by sporadic? Let me tell you. Actually, sporadic mean that it is not associated with genetic, it is not run in the family. Okay, and some are associated with multiple endocrine neoplasia, example parathyroid tumor, pituitary adenoma, and for the pancreas here they show us a gastrinoma. So why? Because our duodenum do have some G cells, our pancreas also do have some G cells, so for that reason gastrinoma is here. But in case of insulinoma will replace this gastrinoma, and that's why it is associated with multiple endocrine neoplasia. Okay, and insulinoma present clinically with recurrent attack of hypoglycemic symptoms. Okay, so that subside after glucose intake. So why hypoglycemic symptoms? Because it is an increased insulin production tumor, so for that reason the hypoglycemia will be there and the hypoglycemic symptoms will be there. Okay, so the diagnosis is established by demonstrating inappropriately elevated serum insulin, okay, and following the fasting test. So let me tell you what does it mean. Actually, we have the normal response to fasting, and we have the insulinoma patient who will react to the fasting. So we inform our patient to don't eat anything for the 72 hours. So then we check the serum glucose. So serum glucose will be decreased, and response to decreased serum glucose, the insulin will also be decreased. Because if we do have the less glucose in our serum, so we don't need high insulin. Okay, so insulin will be decreased. Now look at to the insulinoma patient. So what we found decreased glucose in the serum, but increased insulin production. So why insulin production is increased? Because it is a tumor, and tumor don't listen to the low glucose. I hope you do understand. Now see, insulinoma are differentiated from other causes, okay, of hyperinsulinemia, example exogenous insulin administration by the presence of elevated level of proinsulin and C-peptide. Actually, let me tell you what does it mean. Actually, if our patient is taking the insulin injection, a bolus of insulin, okay, so the serum will show us increased insulin. So yet not we are sure it is insulinoma or it is exogenously insulin administration. Okay, so yet not we are not sure. So how we can sure about it, we will see. Okay, so you can see here it is a pancreas beta cell which produce proinsulin, and proinsulin is converted into insulin and C-peptide. All right, so it is an endogenous process. Okay, normally we produce the proinsulin, then insulin with C-peptide. All right, this is the normal endogenous process. But exogenously, if we administer the insulin, okay, so it will be just insulin, it will be only insulin, not the C-peptide. All right guys, so if we found the C-peptide there, so we suspect it is an insulinoma, not the hyperinsulinemia. I hope you do understand. Then what we see here, you can see in this image. Okay, so we have the C-peptide, we have the chain of insulin. Okay, so this it is producing endogenously. Now what will produce here? Actually, the C-peptide will be removed out, the C-peptide will be removed out, okay, and just the chain of insulin will be there. So C-peptide with the chain of insulin will be there in case of endogenous production of insulin. I hope you do understand. Okay, but in exogenous there is no C-peptide, there will be only increased insulin. I hope you do understand. Now we have the diagnostic. So we can see the hypoglycemia with inappropriate high insulin level. Actually, hypoglycemia don't tell us anything specific. Why? Because this hypoglycemia can be happen because of the adrenal disease, because of the decreased glucocorticoid. Okay, but the fasting test is very important here guys. So patient will have the positive if serum glucose level remain low. So this test will be positive if the serum glucose level remain low and insulin remain high after fasting for 72 hours. Okay, so I have told you the story before. Okay, so if the patient is fasting for the 72 hour and insulin is still high and glucose is remain low, so what we suspect, we rush into the insulinoma. Okay, and if we found the C-peptide there and increase proinsulin, but yet not we are sure it is insulinoma. Why? Because there is another condition which can also increase the C-peptide and proinsulin. What is that? That is a sulfonylureas use. If the patient is using sulfonylureas, so there will be increased C-peptide, there will be increased proinsulin, guys. So this can be ruled out by the serum screening serum sample for sulfonylureas. Okay, so let me tell you what does it mean. Actually, we have the sulfonylureas patient who are taking sulfonylureas. Okay, let's just guess. Okay, so the patient is on the sulfonylureas. Now this sulfonylureas is act on our beta cell of pancreas. Let me magnify it a little. Okay, it is a beta cell of pancreas. Now sulfonylureas is stimulating this beta cell of pancreas. Now this pancreas beta cell producing too much proinsulin. Now this proinsulin is converted into insulin and C-peptide. Insulin and C-peptide. I hope you do understand. So look, guys, in the sulfonylureas we have increased C-peptide and insulin also. And this insulinoma, we have the insulin increase and C-peptide both. So how we can differentiate these two? So we look for the sulfonylureas in our blood. If we found the sulfonylureas in our blood, so we suspect it is an anti-diabetic drug use. Okay, sulfonylureas is an anti-diabetic, and insulinoma is a tumor. All right, now look at here. We have the F cell, it is a pancreas. Okay, just magnify pancreas. Okay, so here is alpha cell, delta cell, beta cell. So this insulinoma is the tumor of beta cell, so there will be rapidly dividing beta cell. All right, now you perform the CT scan and you look for the hyperdense lesion just on the tip of head of the pancreas. Okay, so there will be hyperdense lesion, so you can see in the CT scan. Now you can see here the histopathology. There will be too much beta cell. Okay, so there will be hypernucleated and hypereosinophilic cytoplasm will be there. I hope you do understand. Now it is our surgically resected insulinoma. It is a real case of insulinoma. It is just resected surgically. Okay, so you can see it will be look like this. Now if you perform the surgery, so you look for the insulinoma, it will be look like this. Okay, so that's all about the insulinoma.